Hello. Can you hear me?
Ma'am, please go ahead.
A very good evening and hello to everybody. On behalf of the Society of Indian Physiotherapists, I would extend a very warm welcome to one and all. Let me tell you a little about the Society of Indian Physiotherapists, SIP for short. So the society was formed in 2015 October, and this 4 years and 7-month-old baby was formed with the idea of improving and the status of physiotherapy profession in India. And in this short time, we have achieved a lot. We've had 5 conferences all over India. We've had camps, we've had SIP talks, and we've also had, in this pandemic time, we've reached out to physiotherapists not only in India, but all over the world through our SIPWEBs and SIP chats. So today is the 7th webinar, and we have a very interesting topic in front of you. Pelvic floor fitness exercise, looking beyond Kegels. As we all know, pelvic floor is a blind spot and also an unsung hero, and yet very crucial in every man and woman. And today we have with us a very knowledgeable physiotherapist from Ireland to talk to us. Her name is Shailini Wiseman, and Shailini has done a lot of work in this area. So with these words, I would like to welcome Shailini.
Happy Sunday, everyone, and thank you.
Hello, Shailini. So good to see you. And I just learned that you are from Amchi, Mumbai girl. Yes. That's so great.
Yeah. Thank you, Snigdha. Yeah. Thank you.
Yeah.
Happy Sunday, everyone.
And then you did your graduation from Rajiv Gandhi Health Sciences, right, in 2000.
Yes, I did.
That's so good. And you went on to do your MSc with research at the Cork University, Ireland.
Yes, yeah.
So we are all eagerly waiting to hear you, and I hand over the screen to you. The screen is all yours, Shailini.
Thank you. Okay. Can I be heard clear?
Yes, yes.
Okay. Happy Sunday, everyone. Before I start, I would like to thank SIP and Dr. Snigdha Mehta for giving me this opportunity. I'm a clinician. I have done research in pelvic health, and I'm very passionate about research in this area. So you'll hear me say research says a lot during this talk. Over the last 15 years, women have been moving fast and furious into male sporting arenas. These sports that are considered to be predominantly male-dominated sports are extremely beneficial for women with regards to weight loss, bone, and hormonal health. Over the last 2 decades, large amount of women have been joining the military, and they've been doing exactly the same exercise regime as their male counterparts, and rightly so. But this has then highlighted pelvic floor dysfunctions in sports, which in turn has led to pelvic health physios being a crucial part of the pelvic health team for Olympics and in the military. The reason I wanted to give this talk is because I truly believe in advocates for pelvic health. Hang on a second, I'm not able to move this. And with that, I hope I will be able to give you enough clinical awareness for patient education. So what are pelvic floor issues? Empirically, pelvic floor issue causes were considered to be due to childbirth, chronic constipation, and coughing due to the stretch effect that happens in the pelvic floor. Research has shown that a woman's hiatus takes up to a year to return back to normal after a normal vaginal delivery. Does that mean she shouldn't exercise at all? Not at all. Research has also shown that a large amount of returning back to sports at early postpartum is far more beneficial than not doing any exercise at all. High BMI is the second factor for pelvic floor issues. High BMI is also the single biggest indicator for cancer for women over smoking. Women with high BMI are 3 times more likely to have pelvic floor dysfunctions. But here's the catch. To lose weight, you need to exercise consistently, and you also need to do high resistance training. Many of these women do not exercise because of the fear of their pelvic floor dysfunctions. Not exercising is pretty much like sacking your entire cricket team because your wicketkeeper is not playing properly. Instead of actually looking at the other players and kind of deciding who is causing to this problem, is it entirely the problem of the wicketkeeper? As healthcare professionals, it is our role to educate these women with correct exercises and give them exercises that is pelvic floor safe. The third biggest factor is low back pain. Low back pain and pelvic floor dysfunction has been correlated in many research in both men and women. But 90% of MSK physios just gloss over it. We look at the back, we never address pelvic health. Women with pelvic floor dysfunction, gastrointestinal disorders, and breathing disorders are more prone for low backache. We treat their back, we give them back exercises, we might even give them core exercises, which actually could be detrimental for their pelvic health, and we send them on their way. These women want to get fit, so they start exercising, they have pelvic floor issues, they stop exercising, and their back is at them again. So there's a lovely little merry-go-round that they're going around. As MSK physios, we need to start looking at pelvic health as part of our low back pain protocol. And there's a lot you can do without the need for internals. And as pelvic health physios, we need to get out of the tunnel of pelvic floors, and we really need to start looking at other parts of the body that could be influencing pelvic health. So with that, we're going to look at symptoms. So what are the symptoms you would see in a sporting population? We have a lot of personal biases with regards to sport and what women should or should not do. And this is not evidence-based. Contrary to popular belief, the feeling of heaviness or a stuck tampon or a prolapse is very rare in the sporting population than what we assume it to be. If you have issues with pain during exercise in your pelvic floors or dyspareuria, which is pain with sex, you need to see your urogynecologist and a pelvic health physio before you move forward with exercises. Herman et al. Study looked at over 300 endurance-based athletes, and they found that bladder urgency, dysuria, and straguria were the symptoms they reported more, and the runners reported stress urinary incontinence. What was interesting was that these bladder symptoms were not related to bladder per se, but were more related to pelvic floor muscles. So here is the billion-dollar question. What are pelvic floor muscles and how do they function? Pelvic floor muscles are considered to be a sling of muscles which are attached from your tailbone to your pubic bone. And they have two functions. One is stabilizing the inside of your pelvis when you do stop-start actions such as in basketball. And they're done by your piriformis, your obturator internus, and ilioischiococcygeus to some regard. The remaining muscles have a functional role where they maintain functional continence and are useful for sexual function. But they're actually not sling-shaped muscles. These are diamond-shaped muscles because they're attached to the lateral wall of your pelvis, and they are then divided into anterior triangle and posterior triangle muscle. It is the direction of movement of these triangular muscles that maintain continence, and the cueing for men and women is not one size fits all. So for me to explain this, I need to give you the analogy of the hose pipe. So for men, you need to imagine the hose pipe or a garden pipe is on a concrete surface. To stop the pipe from leaking, you can apply a pressure directly on the pipe and that should do it. So similarly for men, the cueing you would give is lift your nuts to your guts, where you get an upward movement of the anterior triangular muscles, which causes increased urethral pressure over your bladder vesicle pressure, and that should maintain functional continence. In women, however, the pressure you want for functional continence is an upward and forward direction. So for this, you need to imagine that the pipe is on a marshy ground. If you're just going to give a direct upward pressure or a pressure directly on the pipe, that pipe will sink and it won't stop. You need to kink that pipe for the pipe to stop leaking. So the direction of pressure you want to kink that pipe on a marshy ground is an upward and forward pressure. Similarly, for women to maintain functional continence, you need to get them to cue such that they are getting an upward and forward pressure. So the cueing you would give women is pull up your back passages if you're trying to stop passing wind, and pull up your front passages if you're trying to stop passing urine. And you're hoping that the pressure of movement is in an upward and forward direction to kink that bladder neck and increase your urethral pressure over your bladder vesicle pressure. In women, however, it is that forward direction of movement which is a lot more important to be functionally continent. And that is directed more from your posterior triangular muscles. So working your posterior triangular muscles are actually very, very important. So what are functionally fit pelvic floors? Empirically, a functionally fit pelvic floor was considered to have a muscle power of 3+/5 on the Oxford scale. You were able to hold your muscles for over 10 counts. You were able to repeat it and hold if you wanted to pass wind during a yoga class, and do it through a sequence of poses without actually thinking too much about it. So why is that we still have women and nulliparous women who have great pelvic floor strength, who are able to do a full pull-up, and they're still incontinent with sporting activities? And we are telling them to go back and Kegel themselves, and they're really killing themselves doing pelvic floors, but are not being functional. Because research has found how your pelvic floor works to maintain functional continence is very different to how your pelvic floor works with ground force reaction generating exercises such as running. When you run, as you strike your heel, your pelvic floor lengthens. And as you go from heel strike to midfoot to toe off as you run, your pelvic floor recoils back. So with ground force reaction generating exercises, your pelvic floor moves in a lengthen and recoil tone up. So the movement is like a jellyfish, where there's a lengthening and recoil tone up happening. Unluckily, this is not voluntary. This is under our autonomic control. It comes from our brain. So what can we do to actually improve it? Because this is the movement that is required to be functionally fit in sports. That lengthening action we know requires a certain amount of flexibility. That flexibility can be gained with diaphragmatic breathing, because we all know with proper diaphragmatic breathing, there's a harmonious relationship maintained between the diaphragm and the pelvic floor. The reflex recoil tone, however, is a gift from the gods. Some of us have better tone, some of us don't. But we also know stronger the muscle, better the tone. So there is a role for conventional pelvic floor muscle training in sports. But we need to train our muscles in a functional exercise manner where the muscle is able to lengthen and recoil up. And that function happens with ground reaction force generating exercises such as, say, jumping. So here's a thought. Should we be adding low impact bouncing exercises as part of a functional rehab for our pelvic floors? Think about it. Now, this is a self-awareness exercise. I'm not teaching you pelvic floors, because I do think if you can look at your tricks and you can correct your own tricks, you're able to take this on and teach your patients what to do right. We're going to train the marathon runners and the sprinters, but like I said, it's a self-awareness exercise. I want you all to sit up straight, and I want you all to rock back and forth on your ischium till you find that nice aha spot where it's nice and comfortable. Now, we're going to start with the marathon runners, and we're going to pull up the back passage in the front, and we're going to hold for 5 counts. So here we go. I want you to pull up your back passage as if you're trying to stop passing wind, and pull up your front as we're trying to stop passing urine. Hold it for 5 counts. Hold, 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 let go. Let it lengthen and back to normal. Again, pull up the back, pull up the front, hold, 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 let go. Try again for me. Pull up the back, pull up the front, hold, 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 let go. Now, we don't have time to work it up to endurance, so we're going to go into your fast twitch muscles or your sprinter muscles of your pelvic floor. So I want you all to sit up back onto that aha position of your ischium. And I want you to quickly pull up the back and front, let go, quickly pull up the back and front, let go, quickly pull up the back and front, let go. Excellent. Now, like I said, this was a self-awareness exercise. I wasn't teaching you pelvic floor exercises. How many of you felt you had to hold your breath to pull up your pelvic floors where your chest was moving up to your chin? How many of you felt you were like the Bond girl where you were overusing your obliques, you were an oblique clencher and pulling in your tummy to get that perceived sense of contraction? And you'll always know oblique clenchers because they have this big flaring at their ribs and they have this very defined line above their belly button. And how many of you were like Katrina, where nothing happened? Nothing in your body moved, you had a complete poker face, you were able to pull up your pelvic floors and no one knew what you were working. But here's the problem. We all need to be like Katrina. However, majority of us are clenchers. We women want a flat stomach and a tiny waist second tall piece. So we go about the whole day pulling in our tummy. When we start pulling in our tummy and overusing our obliques, we lose the diaphragmatic excursion that takes place. As we breathe into our belly, our diaphragm descends and our pelvic floor lengthens. As we breathe out, our diaphragm recoils up to push that air out of our lungs and our pelvic floor recoils in reciprocation. When you keep that tummy and obliques clenched in all the time, there is no diaphragmatic excursion, so you can't breathe. So what do? You raise your chest up and you become an apical breather, and you end up breathing into your chest where you lose your diaphragmatic excursion, and you might even use your accessory muscles, which can be seen in Alia, where her neck muscles are very prominent because she's used her obliques and she's breathing using her accessory muscles. The problem with this increased intra-abdominal pressure constantly on your pelvic floor is over time, your pelvic floor will adapt by shortening and tightening. And that's how it remains to counteract this increased intra-abdominal pressure. You have changed your posture because you can't actually breathe with your obliques and your abdomen pulled in. So you go into an apical breathing, so you lose the excursion and recoilability of your pelvic floor as much, of your diaphragm as well. And then you decide that I'm going to join a 10K run because Milan Soman is in town and he is running. And who doesn't want to run behind Milan Soman, right? So you start training. Problem is you've gone about your pretty much half your life pulling in your core and using your obliques. Your pelvic floor has adapted in a nice, short, tight manner to compensate and react for that increased intra-abdominal pressure. And now as you run, you're expecting your pelvic floor to lengthen and recoil, which is pretty much impossible. Then your pelvic floors start getting tighter to protect you, irritate your bladder, cause you bladder symptoms, and then cause you stress incontinence. So what can we do to change this pattern in women? Telling women to let go of their abdomen is pretty impossible. So you need to start with teaching them diaphragmatic breathing. To teach diaphragmatic breathing, I will always teach it in sitting. Lying down is good, but not to get them conscious of using their obliques. So I want you all to try this. I want you all to sit up straight with your knees quite wide apart. Lean forward for me. When you lean forward, you're not leaning from your thoracolumbar junction, you're actually leaning more from your hips. Now, the cueing you would tell people is breathe into your belly to raise your belly up and get them to breathe out. So you get them to practice diaphragmatic breathing. The reason being is when you lean forward, you naturally let go of your obliques. Hence, the direction of breath can be changed to diaphragmatic breathing, and it makes it easier to learn diaphragmatic breathing. So the direction of breath you'd advise is breathe into your belly and blow out. And breathe in again to your belly and blow out. And you have to lean forward for this. In this position, you can get them to start initiating pelvic floors for functional rehab. But you're only going to initiate your posterior chain muscles because you want a bit more lift in the forward direction. So you're going to get them to breathe in and blow out. And as they blow out, they're going to pull up their back passage very gently as if they're trying to stop passing wind. But here's the trick. If you are blowing out and you're blowing out as if you're only blowing a candle or 100 candles, it won't work. You have to blow out a long pursed lip blowout as if you're blowing a burn on your finger. And with that burn on your finger blowing out, you're going to try and initiate your pulling up your back passage. So to get women to start diaphragmatic breathing and disengaging their obliques, you want them to sit up straight, lean as forward as they can, get them to do diaphragmatic guided breathing where they're breathing into their belly and blowing out the burn. And once they've got that right, you get them to breathe into their belly, blow out the burn, and as you're blowing out, pull up the back passage gently, hold, 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 and let go. And that generally should get them rehabilitated to stop doing trick movements. And it's also the simplest and most functional cue of just using the back passage. So how much percent contraction is required? Nothing. When you are running, we shouldn't be pulling up pelvic floors. But in some women, you might need a certain amount of contraction, especially when they're doing jumping jacks or skipping. Research has shown that 50 to 70% voluntary contraction of your muscle produces exactly the same urethral pressure that is required for functional continence as 100%. 50 to 70% voluntary contraction is also functional and it's easier to maintain. So getting women to try different activities, and if they need to pull up certain amount, pulling up 50 or 70% of just their posterior chain muscles is far more than enough. Now, we're coming back into research again. Research has shown that athletic nulliparous women who participated in more sports such as volleyball and basketball generated greater perineal pressure than non-athletic nulliparous women. So if you take anything out of my talk today, the fact that our young children and girls and boys need to do more exercises and do more jumping and hopping and ground reaction force-based exercises and carry this on to their teenagehood and young adulthoods for better pelvic health, my job is done. Okay? So when not to do pelvic floor exercises? If you have any of these symptoms, do not advise them to do any form of pelvic floor exercises. They need to review a gynecologist and a pelvic health physio before they move forward. But diaphragmatic breathing is therapy for all these conditions. So we're back to running again. I've been hammering on about the length and the recoil that takes place as you heel strike and come up to toe off when you're running. But here's our problem. 75% of women adopt a posterior tilt posture at 6 months postpartum, and they carry on this posture for 75% of the women adopt a posterior tilt posture at 6 months pregnancy, and they carry on with this posture for 6 months postpartum. Many of perimenopausal women also have a posterior tilt posture because of muscle weakness that happens with aging and not doing any resistance training. When you adapt a posterior tilt posture from 6 months pregnancy to 6 months postpartum, you end up losing gluteus medius and you're only left with the gluteus maximus. That's why a lot of women complain of a sagging ass when they are they're postpartum. Because you're in this nice slouched posterior tilt posture, women feel they're not standing straight. So how do women stand straight? By raising their chest. When they raise their chest, they change their breathing into an apical breathing. Then they feel their tummy is slouchy, so they end up pulling in their tummy, and they do huge amount of core-based exercises postpartum, which actually causes more core rigidity than core strength. Then they're not still happy with their personal appearance, so they decide to lose weight, and the primary choice of sport to return to lose weight is running. And you're running on a weakened glute with a posterior tilt with apical breathing and a pulled in core. So research has shown that training posterior chain muscles such as your glutes and hams along with your anterior chain muscles are far more beneficial. So at 6 weeks, I would start training my women with the bird dog, lunges, squats, and crab walks. I would give them TheraBands, and I'd give them kettlebells, and I get them lifting heavy. But here's our problem. These exercises are linear exercises. Majority of the physio exercises are linear. Running is not a linear exercise, neither is motherhood. We need to look at multi-planar exercise to rehab our postpartum women. So I would start them with a bear hold and a loaded beast at 6 weeks postpartum. And from there, I would progress them into a forward bear crawl and lateral bear crawls with TheraBands, because this is a great multi-planar exercise. It strengthens anterior chain, posterior chain, and lateral chain muscles. And if you look at a bear crawl and you turn it from horizontal to vertical position, it actually is running. So you're getting them much more functionally fit for running. So for women with issues with running, you want to look at the following things. One is, how is their posture? Are they very chest up, oblique clenching posture? Get them to do timed breathing in and blow out the burn as they run. So that nice long pursed lip blowing out that they do when they run. And they might need to pull up their pelvic floor slightly if they require. But here's a bit of a maverick thinking. Lintner et al.'s research looked at continent and incontinent runners and found that when women increased their speed to 11 kilometers per hour, their reflex voluntary contraction of the muscle increased to 100%. And when they increased their speed even to 15 kilometers per hour, that reflex voluntary contraction increased to 150%. So if we are training with just conventional pelvic floor, wouldn't it be a very nice maverick move to start training women with sprinting and speed-based exercises as well, so that we can actually get the pelvic floors to adapt better? Think about it. Now, with regards to weight training, unlike popular beliefs, deadlifts does not increase intra-abdominal pressure compared to sit-ups, curl-ups, and Pilates hundreds. As physios, we are far more comfortable giving patients Pilates hundreds than deadlifts. And deadlifts are far more functional because they train anterior and posterior chain muscles compared to Pilates hundreds. The women in our villages are already doing deadlifts. What do you think they're doing when they're lifting that big bag of grain and throwing it across their shoulder, or lifting those big heavy pots of water? Those are deadlifts. Squats and lunges are also quite good. They do not increase pressure onto your pelvic floor as long as you don't grunt or bear down or hold your breath and lift. Ideally, I would tell the women to blow out the burn and then lift up and engage if they need to. Here's the ultimate test for your pelvic floor. Jumping, skipping, and trampoline are the ultimate test for your pelvic floor. But think this. Your brain tells your pelvic floor to recoil and brace up even before you jump. And then you jump. There is an involuntary reflex that your brain sends saying, pull up, hold, and let her jump. With brain, if we don't use something, we lose it. The brain says, forget it, you don't need it, leave it aside. So for getting women to get functional training so they can actually jump with their children or run after a bus, getting their brain to send that reflex recoil is very important. So training them with low impact loading exercises and jumping exercises is actually very crucial for pelvic floors. Now, In some women, they do require some sort of support because they have a structural defect. Cube pessaries can be fitted by your gynecologist. Get your gynecologist to fit the cube pessaries. Women can use this with exercise, and after exercise, they can pop it out and go. So here are my few pelvic health mantras. For women over the age of 45, if these symptoms are new, you need to review your GP or your gynecologist for estrogen cream, because lack of estrogen in your body can also cause pelvic floor weakness. As physiotherapists, we should be looking at non-linear exercise drills for strengthening our postpartum mums. We need to be looking at speed drills and low impact bouncing. With athletes, we need to get them doing timed breathing in and blow out the burn as they run. And they might need to initiate certain amount of pelvic floor exercises. But my biggest take home mantra is practice belly breathing. The more you practice belly breathing, the better length and recoil takes place naturally in your body. This is not just good for your pelvic health, but also for your mental health. So do it as many times as you can and do it like meditation almost. Now, here's something to think about. Our ancestors were very, very smart. They introduced Bharatanatyam and Kathak in young girls, and I believe that was to improve their pelvic health. The thing is, we haven't capitalized it and we haven't started using this for rehab in our older women. Bharatanatyam has tons of lunges, single leg squats, single leg standing, Cusack squats with a lot of low level bouncing exercise to really high level bouncing exercises. Yoga was popular in India before it became popular in the West, but it was marketed better in the West and then it came back to India. I think there's a big role for Bharatanatyam as a rehab exercises, especially for functional rehab, to strengthen your anterior chain muscles, posterior chain muscles, lateral chain muscles, and to get that lengthened recoil going, to get that brain signaling to the pelvic floor to do that lengthened recoil going, along with good diaphragmatic breathing. So if anyone knows Bharatanatyam and wants to collaborate, give me a shout. Now, this is a 56-year-old woman I know who is a mum of 3, and this is how she sits and washes her utensils. So if anyone's there thinking Indian women can't do it, maybe we should think of Bharatanatyam as a rehab exercise, which might be more acceptable for Indian women to do than speed drills, and it's also multi-planar. And if people are there thinking Indian women aren't fit, think again, look at this woman. And with that, thank you and questions.
Thank you so much, Shailini, for that enlightening, crisp, and lucid presentation. You demystified it beautifully. Thank you so much.
Thank you.
I was amazed at the way you talked about the runners and the pelvic floor exercises. And I'm so happy you talked about the diaphragmatic breathing, which should be incorporated. And I was also very pleased to learn about the Bharatanatyam and the yoga practitioners. And women in yesteryear in our country always squatted and did all activities.
Exactly.
And they had 10 children and the pelvic floor was just amazing. It wasn't like what it is today.
Yeah, and the research is coming back saying actually we need to start loading our pelvic floor. Even if you have pelvic floor issues, doing that low impact bouncing sends that signal from your brain, prepare to load and recoil up. But if we don't do it as older women, we lose that signaling pattern. So it's important that we just don't focus on pelvic floor exercises. We look at multi-linear, multi-planar exercises along with low impact loading.
Right. So your advice about non-linear exercise was great. And also the advice given to youngsters to jump and do all kinds of physical activities was also, I think, a very good take-home message. I also want to ask you a few questions. We have a lot of questions coming from the audience. What is your take on prolapse of the uterus and pelvic floor exercises.
Now, prolapse is a funny thing because you can have someone who has a first-degree prolapse and is very symptomatic, and you can have someone with a good second and third-degree prolapse and not symptomatic. You can do weight-bearing exercises, but you need to see how their symptoms are. If they have a very large prolapse, and if you think that there could be a lot of bearing down or grunting movements with the exercises, using a cube support is actually quite beneficial.
Right.
But there's a lot of weight training that you can do, which can be modified. So I'll give you the example. You want to train the anterior and posterior slings of women, especially as they're going through menopause, because with menopause, there's lack of estrogen, and hence you tend to lose muscle mass. But you can do deadlifts without the need of lifting the weight from the ground up. You can get them to put it on 2 boxes and put it up on the side where the weights are coming, the bar is coming mid shin level, and lift from there. So there's not that much increased intra-abdominal pressure. So giving the advice that don't do weights in women is completely not appropriate. It is our role to look, be creative, and modify the weight training so that they still get the benefits of strengthening the muscle. And let me tell you, there is a research that's recent enough by Fauna et al. It's 2019, and they surveyed women, and they found that women who were lifting over 60 kgs actually reported far less prolapse symptoms than women who were lifting just 5 and 6 kgs. So lifting heavy is very important for women. And this is how I tell it to a lot of girls. If you look at the girls working in the farms or even our rock breakers, what they're doing is CrossFit. Yeah, it's just not fashionable CrossFit, it's their livelihood. And they are strong. They are very, very strong women. Yeah, and chances are they have far more bone health and better muscle mass than the women sitting in front of a computer.
Right, absolutely.
So it is really important for women to weight train, but weight train even to load the muscles in your pelvic floors. Okay, we're coming from a very different approach in terms of how we're looking for fitness, because if our pelvic floor reacts with that nice length and recoil, unless you're getting that length and recoil happening, how are you going to train it functionally? For functional continence, you want that upward and forward direction of movement, and that will happen by just activating your posterior triangular muscles. But that length and recoil can only happen with functional activities, and this is why I sincerely believe that Bharatanatyam has a role to play in it, because we're doing so much of squats, so much of single leg standing. There's a lot of those little thumping movements that they do with the squatting, yeah, and then they progress on to higher thumping movements, yeah. So there's that bounce that's naturally coming. Our ancestors were very, very intelligent. Somewhere along the way, we forgot about our heritage. Yeah, so there is a big role. It's a question of breaking it down as a rehab exercise, making it acceptable, and making it trendy for the young.
Yes, right, absolutely. Yeah. So I was just thinking about those women in the villages carrying those pots on their head, you know, and walking miles and miles. I'm sure their pelvic floor muscles were naturally getting activated when they did that, because the stability was
Yes. And if you think about it, these girls have been doing that lifting of that heavy pot and then putting it up on their head since they were little girls. So their muscles have got that brain and muscle signal going, react now, she's going to lift up. And in the CrossFit world, that lifting and putting things over the shoulder is called lifting deadlift with a kipping.
Yeah, absolutely.
Or a clean jerk. But our women have been doing it for ages. It's a question of making it trendy as a rehab exercise.
Right.
We need to start getting our women to lift weight. Do not have biases towards it. As physios, we are very good at giving linear exercises. We give them tiny 2 kg weights. None of my women start with 2 kgs postpartum. If they come to me 8 weeks, they're going with 6 kgs, 8 kgs, 10 and 12, and we're progressing upwards. Because if you take the whole weight of the pushing buggy and a baby together while they hold in their arm, that's equivalent to about 15 to 20 kgs at least.
Right.
So why are they coming to an exercise class and lifting 2.5 kgs?
Right.
What a waste of time.
There's another question that I would like to answer. Suppose the woman has had a C-section. Does
Yes.
the protocol change in postpartum time?
No, not really. So you wait for the average healing time of 6 to 8 weeks. If they don't have any issues and scar mobility issues, they can start with lifting at around 12 weeks. So it's not, you don't need to actually change it. You can again modify it, because I would give a lot of my C-section women to start with things like bear holds at around 8 to 12 weeks, depending on their comfort. And if they are comfortable, I would get them to do forward bear crawls and lateral bear crawls. And from there, I would go into multi-planar exercises that you can do. So there are ways of modifying it. You just need to, and it's a question of physios being creative for the patient, because there is no one size fits all. You have to tailor it to a patient. Sometimes with C-section, I do get them going early on with scar tissue massage. So that just helps in terms of their mobility factor. And again, deep breathing, diaphragmatic breathing is a must, irrespective of what birth you've had, whether it's a roof birth or a vaginal birth, you need to do diaphragmatic breathing.
Right, right. Any take on women with diastasis recti?
Yes, so this is very interesting, and diastasis recti is a very hot topic now. But if you can teach a woman to do controlled loading, that should make a difference. Diastasis recti is separation of your rectus muscle because of collagen weakness, right? For the collagen to load, you actually need to load it with weights, because you see better constriction of the collagen when you actually start loading it. So if you're starting with basic abdominal rehab, like your TA and stuff, at some stage, you need to start looking and seeing, can they keep their tummy in so that they're not having that coning or that bulging, and then can they start loading their abdomen with bit of weights. So one of my favorite exercises to start with for a woman is, once I've got them to learn to control their doming a bit better, is getting them to lie down with their feet on the floor, getting their hands with the weights on the side here, and just starting to load up and down. Because when you do that with weights, you're holding your weights here or a kettlebell here, when you start doing that, you start using your rectus and your obliques to some extent. And you're bringing the dram to come closer, and loading the collagen has a better effect in bringing it closer, as long as you're not ballooning and bulging while doing it. So it has to come with a certain amount of control. They're not a push forward group.
Right. So there are lots of questions that have come up. I think we have reached the limit of time. So I would like to thank you so much for this wonderful eye-opener, I would say. And on behalf of the Society of Indian Physiotherapists, I would profusely thank you for this enlightening conversation and talk. And I would also like to thank our Society of Indian Physiotherapists President, Dr. Raju Parashar, our Secretary, Nitesh Bansal, and of course, all of you viewing right now. Thank you so much. And of course, a very heartfelt thank you, dear Shailini. It was indeed a very eye-opening, enlightening presentation. Thank you so much.
Thank you. Thank you, everyone.
Thank you.